Good afternoon, everybody, and welcome to our web-based seminar, Diagnosis and Management of Tuberculosis in the Pregnant Patient. My name is Lee Reichman. I'm the Executive Director of the New Jersey Medical School Global Tuberculosis Institute, and I will be moderating today's program. The management of patients infected with M. tuberculosis can be complicated and challenging in the presence of other medical conditions. This web-based seminar will specifically cover screenings, diagnosis, treatment, and management of TB patients who are pregnant. The seminar will consist of an overview of the current practices and recommendations related to this population, as well as issues around the TB in women of childbearing age. The case presentation will be included along with time for discussion. Our faculty members today are Dr. Chai-Ling Nan Chang and Dr. Jane Carter. After this introduction, Dr. Nan Chang will provide a review of the management of tuberculosis pregnant patients. This will be followed by Dr. Carter, who will present an interesting case. In the interest of time, we will hold questions and discussion until the end. We'll now begin with Dr. Chai-Ling Nan Chang. Dr. Nan Chang is Assistant Professor of Obstetrics and Gynecology in the Division of Maternal and Fetal Medicine at Columbia University College of Physicians and Surgeons in New York City. I'll now turn the program over to her. Chai-Ling?
Well, thank you again, and thank you to the Global TB Institute for providing me the opportunity to discuss a challenging topic, and a topic that sometimes can cause hysteria, even to people who are very familiar with tuberculosis and pregnancy. To start off with, this topic is very important because we're not taking care of just the patient. We're also taking care of her unborn fetus, as well as any other children in her home. So at the end of the seminar, I hope that everyone will be able to understand a little bit about tuberculosis in reproductive age women, what is entailed in prenatal care in the United States, the screening guidelines that are currently endorsed by the CDC as well as the American College of Obstetricians and Gynecologists, to learn to recognize the screening guidelines, the signs and symptoms of TB in pregnancy, the treatment guidelines in latent and active tuberculosis in pregnancy, a little note about postpartum care and breastfeeding, as well as family planning strategies, and to have a short discussion on deficits in the research in this topic. So first, I will move straight ahead to tuberculosis in reproductive aged women. So we all know that tuberculosis is a global problem, and over 900 million women worldwide have tuberculosis. Although men are more likely to become infected, women are more likely to progress to active disease. In reproductive age women, which is defined as women between ages of 15 and 44, tuberculosis contributes 9% of all deaths. As a comparison, HIV and AIDS, as well as heart disease, only contribute to 3%. Now, the majority of those who are infected with tuberculosis do not have the active disease, and untreated, approximately 10% of infected patients will develop active tuberculosis, and this is primarily in the first 1 to 2 years after the infection. We know that worldwide TB kills more women than any other infection, and most of this is due to avoidance or lack of access to medical care. I would also like to point out that the numbers of women with tuberculosis may be smaller, less than is reported due to underreporting of TB in women. So in the United States, due to current guidelines, we know that there's a significant decrease in number of tuberculosis cases, particularly in the last 20 years. The most recent number that we have is from 2009, and we have approximately 11,000 cases of tuberculosis that have been reported. This is followed with a decrease in number of tuberculosis deaths as well. This is mostly due to the decrease in the number of U.S.-born cases of TB in this country. However, you note in pink that the number of cases of foreign-born persons has remained steady throughout the last 20 years, despite our best efforts. Tuberculosis in general affects women in the following categories, and approximately 6% are represented in women who are less than 15 years, 11% 15 to 24 years, and those who are 25 to 44, 34%, and 30% in those who are 45 to 64 years. I'd like to point out that individuals who are in the reproductive age group comprises of 45% of those reported TB cases. However, as any obstetrician will tell you, due to the number of increase in teenage pregnancy as well as the increase of pregnancy in women over the age of 45 through artificial reproductive technology, the actual number may be over 50%. Tuberculosis in pregnancy was initially treated with fear. Women were offered terminations of pregnancy. However, contemporary studies show that this is not necessary because those who have pulmonary tuberculosis who are treated appropriately in general do not have increased rates of maternal complications or neonatal complications. Specifically, we can talk about vertical transmission, and there is a theoretical risk of transmission of Mycobacterial tuberculosis, and this has been found in amniotic fluid. It has been found in pathological specimens in placenta and granulomas, and there have been a few reported cases of granulomas found in neonates. However, these autopsies are always performed postpartum, and it is very difficult to dissect out whether the neonates were affected intrapartum or postpartum through horizontal transmission. In any case, the identification of TB granulomas in the placenta may only reflect that the mom has a disease, and it does not necessarily mean that the fetus has congenital tuberculosis. Tuberculosis could be transmitted in the antepartum period through fetal aspiration of infected amniotic fluid or through direct hematogenous spread through the placenta. In the intrapartum, in theory, the fetus can aspirate or ingest infected amniotic fluid or genital secretions. And in the postpartum period, there could also be inhalation ingestion of respiratory droplets. There is a higher incidence of congenital tuberculosis in women who have extrapulmonary tuberculosis. And in a sample set of women who have active tuberculosis, 15% of the neonates sampled in the first 3 weeks of life actually have tuberculosis, bacillus. This is either due to vertical or horizontal transmission, and due to the fact that it is difficult to diagnose congenital tuberculosis, we really don't know exactly which period the fetus is at highest risk. What we do know for sure is that tuberculosis in women who are HIV positive is an insidious disease, and that there is an increase in the amount of intrauterine infection of in fetuses who are born to mothers with concurrent TB and HIV. The rate of HIV transmission to the fetus is reported to be as high as 19% in women who are co-infected. This is compared to contemporary data showing that there's a 5 to 10% risk of vertical transmission of HIV to the fetuses. And in places, for instance, the United States and Britain, where all patients with HIV receive heart therapy, the actual transmission rate is actually less than 1%. So you can see that there's a dramatic difference between those who are treated and those who are untreated. So what exactly are the risks of tuberculosis to the fetus and to the mom during the pregnancy? We know that in latent tuberculosis, there's not an increased risk to the fetus. There is an increased risk of postpartum tuberculosis transmission through horizontal transmission. In active tuberculosis, the complications are actually quite controversial. We know that in the United States, there is a higher prevalence of active TB expected, particularly in cities where there is a high number of immigrants. And in a report from New York City looking at Kings County Hospital and St. Vincent's Hospital between the years of 1985 and 1992, there were actually 16 cases of reported active tuberculosis in pregnancy, which actually represents to approximately 1 case per hospital per year. And most of these are, many of these are actually secondary to extrapulmonary tuberculosis. So what happens in pulmonary tuberculosis in pregnancy? These are all the large studies that have been reported over the years. There seems to be a discrepancy between whether or not there is an actual risk of increase in prematurity. In the more contemporary studies, we see that there is. However, in the larger studies based in the 1950s and 1970s, this data is controversial. There is also reported to be an increase in lower birth weight in mothers who have active TB. And lower birth weight is defined by the American College of Obstetricians and Gynecologists as babies who are born less than 2.5 kilos. Concurrently, there's also not controversial data, but inconclusive data regarding whether or not the fetuses that are born to these mothers are growth restricted. Growth restriction is defined as any baby that is born that is less than the 10th percentile. Other outcomes have been examined, for instance, perinatal death, fetal distress, and maternal complications, and at best this data is at this time inconclusive. However, in the case of extrapulmonary TB, the evidence is clear. There is a report of increased maternal and neonatal outcomes. One of the largest studies on extrapulmonary tuberculosis in pregnant women was published in 1999 through a New England Journal of Medicine, where they looked at 33 cases of women with extrapulmonary tuberculosis. The majority of them were treated, and this was compared to normal healthy controls. And they have found that extrapulmonary tuberculosis can be presented in practically any organ. And the key finding is that if the extrapulmonary tuberculosis is confined to the lymph nodes, then this is likely not to have any impact on obstetrical outcomes. The mean birth weight of these fetuses are decreased compared to those with lymph node-only TB. The rate of low birth weight is also increased in those with extrapulmonary tuberculosis compared to those with just lymph nodes. And the APGAR scores are also decreased compared between these two groups. However, as an obstetrician, I would like to note that an APGAR score of less than 6 at 1 minute is not clinically significant. For the purpose of clinical as well as basic science research, we consider an APGAR score of less than 6 at 5 minutes to be significant, because that is the APGAR, that is the time frame where we feel that fetuses will have childhood complications and neurological impairment. Now, what's the big deal about low birth weight? Low birth weight is actually one of the rising problems in the United States and worldwide. And the reason is because low birth weight contributes to a large number of neonatal complications as well as adult complications in these children. In the neonatal period, these children have an increased risk of respiratory distress and intraventricular hemorrhage. They also have an increased risk of patent ductus arteriosus, or at least a delay of closure of the ductus arteriosus, and increased risk of necrotizing enterocolitis and retinopathy of prematurity. As an adult, we know that through the Barker hypothesis, these children with time develop metabolic syndrome-like complications, including hypertension and type 2 adult onset diabetes, and they are at increased risk of developing heart disease. So the children who are born with low birth weight are at 10 times the higher risk than their normal weight compatriots of developing metabolic syndrome. So the impact of tuberculosis is compounded with the presence of HIV in the mother, and this is a topic that really we could discuss more than an hour on by itself, but I'd like to give you a summary on one slide to show you that in women who are co-infected with HIV and tuberculosis, there's a significantly worse maternal and fetal outcomes, and there's multiple studies that have indicated that the mothers have increased in maternal death. There are lower CD4 counts compared to women who have TB alone or HIV alone, and this as well as other complications account for a very high antenatal admissions during the postpartum period for any complications. These fetuses are also at significantly higher risk. They have increased perinatal death, increased prematurity, as well as increased low birth weight, and increased true growth restriction. There's also an increased rate of both TB and HIV transmission to these infants, and I'll go over these in a little bit more detail. And the reason why we think there are all these complications to the mom is because of the synergistic effect of the diseases, but to the fetus, most likely it is secondary to malnutrition. So the next topic is prenatal care in the United States. What do we do? What is most often done during a woman's prenatal care? We know that there's 6.4 million pregnancies in the United States, and the most recent data is from 2005, and the majority of these pregnancies are unintended. Having said that, approximately 13% of all pregnant women are uninsured, and this is a problem because uninsured pregnant women are less likely to seek prenatal care early in the first trimester or any prenatal care at all, and they're also less likely to receive the optimal number of visits during their pregnancy. 31% of women, of these women, have they have a 31% higher likelihood of experiencing an adverse health outcome after giving birth because of lack of access to prenatal care. In large cities and in most states across the country, we have universal prenatal care assistance program. There are many women who feel that they can't approach physicians because of fear from immigrants of deportation or of other mothers of a large hospital bill. However, in the United States, it is mandated that prenatal care is provided free to all patients, provided that they are aware of the program and they attend a few classes. And a lot of support are given to these women. So in pregnancy, we dictate approximately one visit every month when they are less than 28 weeks. Later on in pregnancy, this is increased to every 2 to 3 weeks until the patient is at 36 weeks pregnant. At that point, they are seen every week. Many people ask how often ultrasounds are performed during the pregnancy to assess for fetal size. And the truth is, ultrasound is a very poor predictor of any growth abnormalities. So ultrasound is only offered in the beginning of the pregnancy for genetic screening purposes. It's offered in the second trimester to assess fetal anatomy, and it is only offered in the third trimester if the care provider feels that the size of the fetus is not appropriate for the gestational age. So all this equates to approximately 5 to 14 prenatal visits in the average woman in the United States. We don't do too much, unfortunately. We look at blood pressure, we check the patient's weight, we check the urine, we check a fundal height, we check fetal heart rate, we check for edema, we order labs 3 times during the pregnancy, but we actually don't assess the patient's temperature or the pulse routinely. What is important to know, and what has been recently updated through the National Institute of Medicine, is the weight requirements during pregnancy. And this was recently published in 2009. And so if you assume that all pregnant women should gain approximately 1 to 4 pounds during the first trimester, then in your average underweight woman, she should gain approximately 28 to 40 pounds during the pregnancy, which is approximately 1 pound per week during the last 2 trimesters. In normal weight women, they should gain approximately 25 to 35 pounds, which also equates to 1 pound per week at the end of the pregnancy. And in overweight and obese women, the weight gain requirement is significantly less than what we think. The optimal weight gain is between 15 to 25 or 11 to 20 pounds, depending on the BMI. And the weight gain per week at the end of the pregnancy is approximately ½ pound a week. These are recommendations put out by the Institute of Medicine. However, in reality, I can attest that this is not what is happening, and most patients gain probably twice this amount in a normal routine pregnancy. However, these numbers are good to know in case you are following patients to see how much weight they should be gaining at the very minimum. So the next topic is screening guidelines, which I'm sure everyone is familiar with, and I don't think I'll be adding anything new to this topic. But the strategy in pregnancy screening is that there are many women who don't see doctors routinely, and the only time they see a physician is when they are pregnant. So this is a unique time period in both U.S.-born and non-U.S.-born women, because this is the first time in the pregnancy when they, when in their lives that they may seek medical care. And this is an ideal time period to reach out to the family and the community that the family lives in to provide screening and care to the immigrant population. So the current screening strategy, according to the CDC and ACOG, is to screen women who are at high risk. Those women are women with an HIV infection, those who have close contacts with individuals suspected to have tuberculosis, those who have any medical risks, those who are born in countries with high tuberculosis prevalence, those who are in medically underserved, low socioeconomic status communities, alcoholics, those who have IV drug use, residents of long-term healthcare facilities, as well as healthcare professionals working in these facilities. There are a few cities and hospitals that provide universal screening programs. However, this is not standard at this time. And if we were to take a step back and look at selected high-risk screening versus universal screening, programs in the setting of prenatal clinics universal programs are probably a lot more effective than risk-based because of compliance issues as well as for other reasons, which I'll go into. In an example, using New York City with a large immigrant population, universal screening was shown to be highly effective, and not only the PPD read compliance, but as well as the treatment compliance postpartum. And in a study that was recently published in the American Journal of Perinatalology in 2009, the authors found that that this is indeed true, that there's a high PPD read compliance of over 90% and treatment compliance as well. And the women who are at highest risk of non-compliance are those who are Hispanic and U.S.-born women. And the ones who are most likely to be compliant are Asian women. And the authors also conclude that this universal screening strategy identified latent tuberculosis in 11.1% of U.S.-born women, women who probably would never have been screened if you were to follow the high-risk guidelines. So what are our screening and testing methods? Screening in pregnancy at this time is routinely done by using the tuberculin skin test with the Mantoux technique. And this has been validated for use in pregnant women through multiple studies. And the millimeters of induration that would be considered to be a positive test uses the same guidelines as women who are not pregnant. So this is no different. Other methods of screening that can be considered are the use of Interferon-Gamma release assays. The reason is because these have been used in large multi-ethnic populations, and this is not affected by patients who have a history of a BCG vaccine, and they're not affected by patients who have a prior infection with a non-tuberculous mycobacteria. The theoretical compliance is 100% of all patients, with the true screening rate to be decreased slightly, maybe due to clotted specimens or phlebotomy failure, but this is significantly higher than the compliance rate seen in the United States overall. In the article in New York, I think that was a different program. This has been recently been approved by the U.S. Food and Drug Administration to be used in everyone, all patients, with no specific comment about patients who are pregnant. However, it should be considered to be a first-line screening method to be used in women who have been exposed to the BCG vaccine, and this is supported by the CDC. This has been recently validated in 2 studies in pregnancy, one of which is just published recently in Kansas Journal of Medicine. And in this study, the authors looked at women who were pregnant, healthy women who are HIV negative between the ages of 18 and 45, and they compared them to women who were not pregnant. And what they did was they performed a TST as well as an interferon test, quantiferon test in all these women, and they actually showed that in pregnant women, 91.2% had a concordant results between the PPD and the Interferon-Gamma release assay, compared to non-pregnant women, which is only 76% in this particular cohort. And their conclusion is that Interferon-TB gold assay is accurate to use in pregnant women, and perhaps even is more concordant in pregnant women. Another study, which was actually published today but available on PubMed through electronic records, is a study done on 333 women using cryopreserved blood based in Africa. And they looked at women who were HIV positive, and they performed the quantiferon test in these women. And they had 281 women with interpretable results. And the results are really quite amazing. 42.7% of these women were positive. Those women who were positive using this method had a 4.5-fold increased risk of active tuberculosis after the pregnancy. And this is even compounded by women who have a low CD4 count. And those women having a positive Interferon-Gamma release assay was equated to an increased risk of maternal mortality, maternal active TB mortality, as well as infant active TB mortality, with very high risks reported. So the conclusion from this study is that a positive quantiferon test for patients who are HIV positive and pregnant were actually associated with increased risk for postpartum active tuberculosis and mortality. And this is something that really is, I think, going to change the community regarding on how women are screened in pregnancy, because it provides a lot more information than just a PPD alone. So what do you do when you have a positive screening test? Well, the current recommendations are to provide a chest x-ray to these women, to reassess them for evidence of active TB through questions, and to encourage their family members to be screened. Now, one of the most common questions that I'm asked by people in the medical field, as well as people in dentistry, is how safe is X-rays in pregnancy? Can we safely offer an X-ray to look for evidence of pulmonary tuberculosis in women who are pregnant? And this has been very thoroughly addressed by the American College of Radiology, as well as by the American Congress of Obstetrics and Gynecologists. And the answer is no single diagnostic X-ray results in radiation exposure to a degree that actually threatens the developing fetus. So, as an example, here's the number of, here's what the fetal exposure is in women who undergo diagnostic testing. I don't include MRI because there's no radiation exposure. What do we know? We know that patients who are exposed to 1 to 2 rads in pregnancy have a 1.5 to 2-fold increase in the risk of childhood leukemia, which increases the rates of childhood leukemia from the background rate of 1 in 3,000 to 1 in 2,000, which is not exceedingly high, but certainly is significant. Higher doses of radiation, for instance, 100 rad and 150 rad, which is practically unheard of in this common age using the newer CT machines, can cause very high risk of mental retardation. Those who are exposed to 100 rad can have a 40% risk of mental retardation, and those who are exposed to 150 rad have a 60% risk of mental retardation. However, as a rule, we say that those who are exposed to 20 to 40 rads are above should be seriously counseled about the risk of mental retardation and probably offered termination of pregnancy. In any case, in pregnancy, what we're seeing is a single X-ray exposure only exposes the fetus to 0.02 millirads of radiation, which is really negligible. Therefore, chest X-rays can be offered to pregnant women without any reservation, particularly those who have a positive PPD. Other tests that are frequently done in pregnancy, abdominal films, hip films, and mammography or CT scan of the head and chest when you're looking for signs of extrapulmonary tuberculosis, can also be safely offered as long as the patient is appropriately counseled. And the radiation exposure is really minimal to these fetuses as well. When it comes to other forms of testing, then the radiation risk increases significantly, and these methods should only be offered to patients if the risk to the mother justifies the risk of exposure to the fetus. So in pregnancy, of course, X-rays are okay. Informed consent should be obtained, especially many radiologists ask that a patient actually sign a consent form indicating that they understand how much radiation their fetuses are exposed to and what this can result in. The abdomen should ideally be shielded, and because organogenesis occurs at approximately in the first trimester, X-ray should be performed after 15 weeks unless the mom has signs of active tuberculosis and needs a workup sooner than this. Other tests that can be performed in pregnancy would be related to those that you suspect have active tuberculosis. And one thing is the gold standard. The gold standard is going to be culture. And the only problem is this takes 2 to 10 weeks. That requires 3 sputum specimens, and those who can't produce sputum specimens can provide sputum induction through inhalation of hypertonic saline, or the sample can be picked up through bronchoscopy. And an acid-fast bacillus stain should be performed immediately. And susceptibility testing should also be performed immediately in those who you suspect to have active TB. Other sources of culture, especially in women who have extrapulmonary tuberculosis, is basically any part of the body that you suspect has this problem. There's a great fear of taking biopsies from women who are pregnant and in performing endoscopies and bronchoscopies. But the risk to the mom is very low, particularly when the morbidity rate and mortality rate from active tuberculosis is high. So this is justified in really any setting. And this can be done through fine needle aspiration, through biopsies, through X-rays of bones and joints, through pylography, again, only if the physician really feels that this patient has an increased risk, and as well as through CSF. And a mutual biopsy can also be performed through chorionic villus sampling. Other forms of testing that can be used as rapid assay, the only problem is this has not been investigated in pregnancy. This is not to say that it doesn't work. Certainly there are many tests that we perform in pregnancy that are based on nucleic acid amplification technology. Regardless, this is not the gold standard. This can be used if only if the rapid results are required, but also should be followed up by the standard, which is a culture. The next topic are signs and symptoms of tuberculosis in pregnancy. And like we all know, it's a great masquerader, and even in pregnancy, it's a great masquerader. It could be really seen in a variety of symptoms. The clinical presentation doesn't really differ too much in pregnancy. Similar profile: fever, cough, night sweats, anorexia, weight loss, malaise, and weakness. However, patients who are pregnant may report fewer of the typical tuberculosis symptoms. And of note, 20 to 67% of pregnant patients with pulmonary TB are unaware of the disease and have no symptoms. Pulmonary signs and symptoms are only present in 1/3 of the patients. So the common sites of extrapulmonary TB are lymph glands, the pleura, the genital urinary tract, especially the uterus and fallopian tubes, the skeleton, the meninges, bowel, peritoneum, pericardium, and skin. And these are all increased in the setting of women who are infected with HIV. So there are numerous case reports of extrapulmonary tuberculosis presentations in pregnancy, and the signs and symptoms have a significant overlap with the typical symptoms of pregnancy, including malaise, vomiting, anorexia, weight loss, and any symptom that the patient reports actually can be a sign of extrapulmonary TB, which is why this is such a challenging diagnostic dilemma. TB is misdiagnosed frequently, which leads to a delay of treatment during pregnancy. Especially, there's a recent report out of the UK indicating that, TB is one of the last things you suspect in a patient who is pregnant who presents with fever. You always think about chorioamnionitis first, and therefore there's a significant delay of treatment. So the differential diagnosis of women with both should be considered in women who have common as well as rare presentations of the symptoms of TB. So of note, extrapulmonary TB has been presented during pregnancy as peritoneal abscesses, degenerating leiomyoma, and ascites, which is usually seen in patients with genital urinary and peritoneal TB. It has also been presenting in patients with nausea and vomiting, back pain, neurological deficits, as well as paraplegia, which were seen in patients who presented with meningeal and spinal TB during pregnancy. The treatment guidelines in pregnancy for latent TB are for postpartum treatment, with the following exceptions: women with HIV, women with a close recent contact with a patient with active TB, and women who've had a recent skin test conversion within the last 2 years. Outside of that, it is now not recommended to treat the patients during pregnancy. Now, having said that, why are we waiting to treat the patients postpartum? And that's because of the fear of the teratogenicity and the toxicity to the fetus of the medications, and as well as the idea that there is a low risk of latent TB to the mother and the fetus during the pregnancy. However, what must be understood is that postponement of treatment may mean that the woman will never be treated because she will never follow up for her treatments. In addition, if untreated, left untreated, women may have a relapse of tuberculosis later on in their life, and they may never follow up and get this taken care of. Compliance is extremely poor in patients with postpartum treatment in the majority of studies, except for the one that I mentioned in New York City. In a San Francisco clinic population, there's only a 42% compliance with the follow-up visits in pregnant women in a tuberculosis clinic after the diagnosis of latent tuberculosis. And in those who actually do present for treatment, there is an 18% treatment completion rate among these women. And the reasons that the authors have identified for noncompliance are due to lack of appropriate treatment referrals, failure for these patients to keep their referral appointments, and then finally non-adherence to the prescribed treatment because the patients feel well, they're busy taking care of the baby, and they don't feel like they need to be taking any of these medications. So the current strategy as it is for treatment of latent tuberculosis in pregnancy is for referral of treatment, is for aggressive follow-up on the part of the prenatal care provider. Strategies that could potentially increase the compliance rate would be the involvement of cultural case managers to discuss with the patient why it is important and to be treated and why they shouldn't fear the treatment process and the follow-up process. Directly observed preventative therapy programs can also be considered in patients who are in the postpartum period because of the significantly high rate of noncompliance. Another reason why women are not treated in pregnancy is because there are many who erroneously feel that it's too expensive But actually, there is a Markov decision analysis model that was previously published using comparing antenatal to postpartum INH treatment strategies. And the authors assumed that if INH is started at 20 weeks gestation for 6 months in pregnant women, and they assumed that there's a 67% completion rate and a 0.1% rate of serious hepatitis with no fetal deaths from maternal hepatitis, then treatment in the antepartum period actually would increase the life expectancy of women, and despite any potential effects of the antepartum treatment group. So here is the breakdown of what the authors have found, and what they see is that that treatment in the antepartum group results in decreased maternal deaths related to tuberculosis. However, countered with a slight increase in death from hepatitis, a decrease in life expectancy as well, which is not really shown here because this is reported in years, but there is an increase in life expectancy, as well as a significant cost savings. It would be cheaper to treat latent TB in antepartum period than to deal with all the postpartum complications, which would account to more than $44 million. If the authors assumed that the case fatality rate of tuberculosis is actually 0.1% instead of 1%, then some of these effects would no longer be seen. There would still be a slightly decrease in tuberculosis-related deaths, the same rate of hepatitis. Still would be a cost savings. However, there wouldn't be a significant change in life expectancy. So antepartum treatment was the least expensive method as proposed by this analysis. And if you assume a 1% rate of fatality, the antepartum treatment resulted in a marginal increase in life expectancy. It's only when the fatality rate drops to 0.1% that antepartum treatment becomes the least advantageous strategy. That would be the case of latent tuberculosis. And in active TB, the answer is simple. You always treat active tuberculosis in pregnancy because the maternal and fetal benefits outweigh any potential harm to the fetus. So we'll go to the medications that we use in pregnancy, and then keeping in mind that organogenesis occurs early in the first trimester. So the first-line agents that we use is INH and rifampin. These are all available on the slides, and you can look at all of them. I'm sure everyone is familiar with these medications. It is known to be pregnancy risk factor C, which means that there are studies in animals that have indicated that there's teratogenicity in highly toxic levels that would be toxic to humans. However, in human studies, as well as human reports, no teratogenic effects have been seen. Both isoniazid and rifampin have been associated with an increased risk of hepatitis. These both can be used in breastfeeding as well. And the only note is that women who receive rifampin should probably make sure that their fetuses get vitamin K. This is provided to all fetuses at birth, but there are some women who refuse any vaccinations or medications to their newborns, and this is an indication where we have to make sure that the fetuses receive the appropriate postpartum treatment. Ethambutol is also one of the other first-line agents. It is also a pregnancy risk factor C, which means that it is teratogenic in animals. It causes neuritis, optic neuritis, in high doses. However, in humans, no teratogenic effects have been reported in the fetuses. It is most likely compatible with breastfeeding. And the only thing that we have to do is make sure the patient gets an ophthalmologic evaluation. Of note, PZA is considered to be category C in terms of pregnancy factor. It is probably safe in pregnancy. However, there's limited data, and because of this, FDA has not approved its use in pregnant women in the United States unless there are certain cases of special cases of extrapulmonary TB or drug-resistant active tuberculosis. And Dr. Carter will go into a little bit more detail, but this is used in other countries but not used in the United States, so I won't spend too much time on this topic. Second-line agents that can be used, particularly in the cases of multi-drug resistance and extreme drug resistance tuberculosis, would be the fluoroquinolones, amoxicillin, clavulanic acid, and para-aminosalicylic acid. Fluoroquinolones are very infrequently used in pregnancy. However, the risk factor is considered to be C due to the fact that there is a high rate of damage to the skeleton in animal studies. In human exposure, there's no real trial, but in the case reports of women who have been exposed to Cipro in pregnancy, there have been no reports of any musculoskeletal abnormalities in these fetuses. So in multi-drug resistant cases, this is certainly something that can be considered and used with caution. Amoxicillin clavulanic acid is a drug that is considered to be a category B in pregnancy, and the reason it's not used as frequently is because in trials involving preterm labor, women who were given this medication had an increased risk of necrotizing enterocolitis in their fetuses postpartum, and this was a significant trend. However, used in women who were who absolutely need this medication due to the need for broad spectrum antibiotics in preterm birth, we still would use it if they have contraindications to using other medications. And then lastly, the other drug, para-amino salicylic acid, is category C. Now, these three medications are not recommended to be used in women who are breastfeeding. The data is not completely clear. Some of them enters breast milk, and if it does enter breast milk, it is in very small, practically immeasurable amounts. However, at this time, if you have any women who are using any of these three drugs, it's probably best to ask them to abstain until they're off of these medications. One medication we do not use at all is streptomycin because it's category D. There's a 1 to 6 risk in hearing impairment and irreversible congenital deafness. Monitoring in pregnancy is fairly simple. We just ask that the liver function test be ordered in women who are taking the first-line medications. This could be done once a month, once a trimester. There are really no standards, and you can see these here. And those women who are using ethambutol should have visual examinations occasionally to look for vision changes in acuity, and this should be done not just on both eyes at the same time, but also should be done in unilateral, because there have been reports of unilateral color blindness and unilateral optic changes in women. One other thing that should be also considered is weight gain monitoring in women with active tuberculosis. And keep in mind, I had a slide earlier about what the optimal weight gain should be in pregnancy. So the last two topics, postpartum care and breastfeeding and family planning strategies, I think are not going to show you anything new except for maybe some of the newer family planning strategies that we currently have. But first, let's talk about breastfeeding. Breastfeeding is the preferred method of feeding for all newborns and infants, and it is recommended by ACOG to breastfeed for at least 6 months for a multitude of reasons. Breast milk does not contain tuberculosis bacilli, so any cases of neonatal tuberculosis, congenital neonatal tuberculosis, would likely be secondary to horizontal transmission due to aerosol droplets. Women who have latent TB should have no contraindications to breastfeeding, depending on what medications they're on. Women with active tuberculosis are at highest risk of transmitting tuberculosis to their babies, and therefore they should be monitored regarding their exposure to the fetus. Any mother with a newly diagnosed untreated active disease should be separated from the infant to prevent treatment until the tuberculosis medications have begun and the patient has negative sputum cultures, regardless of what method of feeding the mother is planning. The exceptions to breastfeeding are any women who are in this following list these are women who are counseled to avoid breastfeeding in any circumstances, regardless of whether or not they have latent or active tuberculosis. So some of the things that need to be approached during the antepartum and postpartum period is family planning, and really this should be initiated during the prenatal care. A patient should be given information, pamphlets about methods, services that will help them meet their reproductive goals while they're pregnant, while they have the time and the energy to consider these options, because some of these options can be implemented immediately in the postpartum period, during their cesarean sections or vaginal deliveries. And all the options that can be considered are non-hormonal methods, hormonal methods, and lactational amenorrhea methods. These are all important to help the mom comply with the complete course of treatment for any latent or active tuberculosis in the postpartum period. And I'll go over this. So there are many different methods of contraception. I won't go into too much detail about bilateral tubal ligations, because they are well known to everyone. They can be performed immediately postpartum through a mini laparotomy. They can be performed during a cesarean delivery, or they can be performed as early as 4 to 6 weeks postpartum through laparoscopic techniques. One of the newer forms of tubal ligation, surgical tubal ligation, is actually tubal occlusion using the Escher method. There's a website, www.escher.com, that indicates this. This is a new technology where the patient does not have to go under general anesthesia, does not have to be operated on in the operating room. It's an office procedure where the patient gets light sedation, or in some cases nothing at all, and a hysteroscope is placed in the uterus, and the tubes are occluded by these coils. 6 months later, the scarring forms over these coils, and so the tube is effectively occluded. This has to be checked with a dye test or the hysterosalpingogram 6 months postpartum, but this is a method that can be considered in women in whom you don't want to expose to any anesthesia or general anesthesia. Other forms of contraception includes a pill and the mini pill. It is a misconception that women who are breastfeeding should not be taking the pill because it will decrease the quality of the milk production, and this is completely untrue. Regular pills, as well as the progestin-only mini pills, have been given to women who are breastfeeding with minimal reduction in breast milk production, and should be considered in women who plan on using these methods in the long term. Other forms of hormonal contraception includes giving the transdermal patch, as well as the vaginal contraception NuvaRing. And then other newer methods to consider would be implants for containing progestin products. These Implanon has been used probably for the last couple of years, and Mirena have been used for approximately 6 or 7 years, and both of these are easy to use for women who feel that they would forget to take their pills every day and who think that they would like to have another child in approximately 3 to 5 years. Implanon is subcutaneous. It's a rod that's placed underneath the skin. It is very safe. It has as good as a pregnancy prevention profile as using the pill under perfect use, as well as compared to those who obtain surgical tubal ligation. The Mirena is an intrauterine device that not only is a great contraceptive, it also has the advantage of decreasing menstrual flow, and in approximately 40% of women, they experience amenorrhea and have no periods, which is really a great thing for some women out there. Other forms of contraception are the typical things, barrier methods. I like to point out that the amenorrhea method can be used in women who do not want medications, do not have the access to medications, or can't afford it. And amenorrhea method can only be used in the first 6 months postpartum and should be used in women who are breastfeeding exclusively, who have, and they have to be amenorrheic during this period. Once they resume any form of bleeding, they should stop this method and switch to something else. And using this method, they can actually prevent 95% of all pregnancies. And not to leave men out, one of the greatest options for contraception is a vasectomy. And under typical use, which I'm not sure what the authors mean by that, but it provides at least a 99% rate of contraception. One thing to think about in women who have latent tuberculosis and active tuberculosis is the risk of infertility. And that's because 1 to 10% of women with a history of infertility have had some form of genital TB in the past. There was actually a study where women who were exposed to, who had infertility, underwent diagnostic laparoscopy, and using peritoneal fluid wash, they found evidence of some form of tuberculosis exposure at some point in their lives in 5.7% of all of these patients. And regardless of whether or not they have had a history of peritoneal tuberculosis, women with even non-genital tuberculosis have increased risk of menstrual disorders, including amenorrhea and oligomenorrhea. So this is something that I don't think is widely studied. I know in infertility clinics in the United States, the PPD is not one of the tests that they routinely do unless there are some abnormalities that they see in the tube. Regardless of this, women diagnosed with infertility, tuberculosis should be highly considered because TB can lead to salpingitis, which can occlude the tube, or impairment of the cilia, which prevents the motility of the ova or the sperm, and this can result in infertility. And these can now all be overcome with artificial reproductive technology. Now, the last topic I want to talk about is any deficits in research in tuberculosis. There really is quite a long list because less money and time goes into studies involving pregnant women than any other disease. One of the things that we can consider doing in the future is looking at more carefully at the drug safety and pharmacokinetics of all the medications, including first and second line agents that are used in pregnancy, particularly in PZA, if this is what the FDA requires. Also, we need to do more research because we need to identify more medications that can be used in light of pregnancy without any teratogenic effects. And this is extremely important due to emerging drug resistance. We can also look at the clinical outcomes of women who have treated extrapulmonary TB to see that if once they're treated, if the risk of prematurity, if the risk of preterm birth, all of these things are reduced after they deliver. And lastly, cost analysis research can be performed to evaluate more carefully antepartum versus postpartum management in all women. This could be done, using a small pilot center. And then the use of quantiferon can also be further investigated. We've only have 2 reports so far, so we can certainly take some time to look at the large scale of the use of quantiferon in pregnancy to see what the results would be like in HIV infected women using non-cryopreserved blood, using standard phlebotomy techniques. And we can also see if the quantiferon can be used in women who have no prenatal care, who show up to the hospital in a way to rapidly test these women to see if their fetuses are at risk, similar to the way that we test for HIV currently. When women who do not have any prenatal care who show up to our hospitals, they undergo a rapid serum HIV test that gives you the results within an hour and allows a neonatologist to decide whether or not the fetus should be treated. So on this note, I'd like to thank everyone for listening and participating, and I'd like to thank Dr. Lee Reichman for inviting me to give this lecture, as well as and encouraging me and coaching me through my medical career. I also like to thank Dr. Theodore Jones, who was my clinical mentor in my fellowship training, who is a specialist in HIV and tuberculosis in pregnancy, and is also the department chair at Wayne State University. Thank you.
Thank you very much, Eileen, for sharing your knowledge and experience with us. Now let's turn the program over to Dr. Jane Carter. Jane is Associate Professor of Medicine at Brown University in Providence, Rhode Island, and is also Senior Consultant for the Rhode Island TB Clinic. Jane has over 20 years of experience in national and international TB program work. Jane will present a case related to today's topic. Jane.
Thank you very much, Lee, and I hope that our case from Rhode Island will actually be able to underscore some of the principles that Dr. Chang just reviewed. I want to start out with the day of the referral for this patient to our clinic. She was a 28-year-old female who had gone to the ENT physician that day for evaluation of progressive hoarseness. At the time of her evaluation, the ENT surgeon did fiber optic laryngoscopy in the office and demonstrated diffuse inflammation and granulomas of her vocal cords. The ENT physician gave her a prescription for steroids for a presumed inflammatory laryngitis, but the patient was pregnant, and so the ENT physician immediately called the obstetrician to discuss the case and what the differential might be, as well as treatment options. Well, the history that the patient had given the ENT was as follows. She was 29 weeks pregnant with twins. In her first trimester, she began to develop significant heartburn, GERD, and vomiting. The vomiting resolved as her pregnancy progressed, but she still had prominent GERD. Her hoarseness had started at the same time, and at this point, she could only whisper. And the statement that she kept coming up with every time when she would describe any of her symptoms was, "Everything started with my pregnancy." Well, why was the TB clinic called at this point? Well, when the ear, nose, and throat surgeon called the OBGYN to discuss this unusual differential and to mention that prednisone therapy was being started, the obstetrician noted an interesting piece of her history. The patient had had a positive tuberculin skin test performed during the first trimester of pregnancy. She had been referred to the RISE TB clinic, that's the name of our TB clinic in Rhode Island, on a non-urgent basis for evaluation of her latent TB infection. Our policy is that when the pregnant patients are referred, we take a note of their due date and ensure that they are scheduled before their at some time before their due date. This patient had not yet actually had her appointment. It was about two weeks farther out. The phone call, though, between the two physicians raised the possibility of tuberculous laryngitis. And so the ENT physician called us at the TB clinic. We, in fact, called the patient who was driving home from her ENT appointment and had them turn around and come to the TB clinic as a same-day appointment. Well, let's first ask ourselves, well, why did she have a tuberculin skin test during pregnancy? Well, she was born in India and had been in the United States for 18 months. Her husband was here on a work visa, and she was accompanying family and had really had no previous screening prior to this tuberculin skin test as part of her prenatal care. So her TST was actually performed as a targeted testing strategy as part of her package of prenatal care. And this is actually the usual way tuberculin skin testing is really performed in our state in our pregnant women. Well, so let's go back to the case. She's now arrived at the TB clinic. Well, on history, she said she had not noticed fevers, she had had no hemoptysis, and she had no other constitutional findings. Her pre-pregnancy weight had been 103 pounds, and she was now up to 116. Her family was most concerned that she was not eating enough. And really, when you pressed her on history, she said that she maybe had a little cough, but she really described it as a throat-clearing maneuver. Her past medical history was unremarkable, and her only medications were Zantac and prenatal vitamins. Her workup that evening at the TB clinic was as followed. The exam was totally unremarkable. She appeared a little bit tired, but well. She was afebrile, and she had a obviously gravid uterus. Her HIV test was negative and had already been performed as part of her prenatal care. Her chest x-ray was performed, and I'll show you that. We arranged for some sputum for AFB smears, and we actually asked her to hold that prednisone treatment until we could sort out what was going on. This was really her chest x-ray, and I think most people would find this fairly unremarkable. There was maybe a little bit of minimal streakiness in the right upper lobe that's right underneath that clavicle, and I think could probably only be seen when we enlarged the chest x-ray. Now, it's interesting, we did a quick literature search right there in the clinic and actually found very few reported cases of laryngeal TB with a unremarkable chest x-ray. Laryngeal TB is usually considered to be a late manifestation of pulmonary tuberculosis. However, her sputum smears came back the next day as smear positive rare. She was brought back into the TB clinic the next morning when we had that result, and she was started on INH, rifampin, ethambutol, and B6. We deleted PZA due to her pregnancy because, as Dr. Chang noted, PZA has not been well graded by the FDA in the United States, and the CDC guidelines at this point in time still suggest no use. It should be noted that through most of the world, however, pyrazinamide is given during pregnancy as part of the routine care, and has not been any problems there. I think it's going to be unlikely at this point that we have much interest in putting together this type of application for the FDA because, as Dr. Chang noted, in the United States last year there were under 12,000 cases. And so I just don't foresee this really happening in any time soon. I think we just need to remember that PZA addition during the first part of treatment changes the length of therapy, but it does not prevent the emergence of resistance in companion drugs. This patient is still covered with 3 drugs, and so that issue of preventing emergence of resistance is already covered. The other issue for our patient is that with laryngeal TB, I think many people would consider a longer treatment anyway, and so I didn't think we had lost anything by not including pyrazinamide in her treatment up front. Well, what was our public health issues that we needed to think about in this pregnant woman? Well, we initiated quarantine as we would for any contagious case, but we really needed to make a plan for ongoing obstetrical care because we couldn't really do that ourselves at the TB clinic. Well, there was no isolation room at the private obstetrician's office, so what we did is ongoing. The patient was always going to be seen as the last appointment of the day with the patient masked to enter the office, and she would not be waiting in the waiting room. She had some tests that had already been requested that needed to be done at the obstetrical hospital. And so again, what we did is we notified infection control at our obstetrical hospital. The patient was masked whenever she was going in and out of the hospital, and we used expedited appointments. She was not to wait in any waiting rooms and really could go have her tests and leave. What happened in terms of her clinical course? She tolerated her medications without difficulty, and what was quite remarkable is that as soon as we started treating her, she started gaining weight, and she gained 22 pounds in the next 8 weeks. Her drug susceptibility test returned as being fully susceptible, and at the time that we had that, her ethambutol was immediately dropped. Now, we were doing sputum collection every 2 weeks because we wanted to try to document when she would become smear and hopefully culture negative so that we could make plans for her delivery at the obstetrical hospital and also know what we needed to do with the babies. Her sputum smear conversion occurred at 4 weeks into treatment. Now, what we wanted to do was to go ahead and put in an infection control plan with our obstetrical hospital because it was really unclear if she was going to be non-contagious, meaning culture negative, prior to her delivery. So what we did is we worked on a TB infection control plan with the infection control officer at the obstetrical hospital. And we came up with the following. If she delivered before she was culture negative, she would have a private isolation room. The staff were going to wear personal respiratory precautions, masks, entering in and out of the room, although one could argue if she was in an isolation room and she was smear negative at that point, would that be necessary, but we could talk about that. She would not visit in the newborn nursery at all. Plans would be made for the babies to be brought to her room. We notified pathology so that they could examine her placenta for granuloma so we could get other ideas about how sick she was at the time of delivery. We were planning on window prophylaxis for the babies if neither of the babies had any evidence of TB disease. And we had already screened the husband at the time of her presentation. He was tuberculin skin test positive, had a normal chest x-ray, and had been started on his INH treatment for latent TB infection already. So there were supposed to be no restrictions on his movements at the obstetrical hospital. So what were our outcomes? Well, Mom was scheduled for C-section, but as I'm sure Dr. Chang would be able to describe, the babies didn't realize that, and so she went into labor 3 weeks early. She was smear negative at the time of delivery, but she was not culture negative. Her placenta showed no granulomas. The babies were placed on window prophylaxis so that they could immediately reunite with the mom. And I'm sorry, Dr. Chang, I should have thought to look it up. I didn't have the babies' weights at the time of their delivery. One of the babies did go to the NICU for about a 3-day stay because of low birth weight and a little bit of respiratory distress in the first day. Well, Mom's cultures. The last set of cultures that we had taken turned out to be 10 days before she delivered. Those cultures eventually demonstrated no growth, and so we felt that there had been no risk of contagion at the time of the baby's birth. So they were taken off their window prophylaxis at 6 weeks of age when we discovered this information. As a precaution, we went ahead and did TST in the babies when they were 12 weeks old, and both were 0 millimeters. And as I said, Dad was not ignored. His TST, which had been positive at the time of his wife's diagnosis, was treated. Mom is now finishing her medications without difficulty. She was treated with directly observed therapy throughout her course, and she had a 9-month treatment course because we did not have that PZA in the first 2 months. It was quite remarkable that it took almost 4 months for her voice to return to normal during therapy. So, from this case, what are some of our lessons learned? I think it is true that targeted testing strategies for latent TB infection can be incorporated into prenatal care. In this era of declining TB rates in the U.S., the diagnosis of disease continues to require an awareness of at-risk populations, so we always have to think about TB. TB treatment in pregnancy is not only safe for mom and baby, but critically necessary for good outcomes. And I have to underscore, I think that the real reason that this case turned out to have a happy ending was that there was tremendous communication and cooperation between services, and that has become a critical component for good TB care in the United States. Communication occurred between the ENT surgeon and obstetrician on the day that the patient was seen, and really that brought the TB clinic into play, and we were able to see her on a same-day basis. Ongoing communication between the TB clinic and the infection control hospital was really critical in managing her care and managing some of the TB hysteria. We would like to highlight that this was an unusual presentation for TB laryngitis with so few radiographic manifestations in the chest. I think the last lesson for TB control is that constant education is necessary. Despite our detailed instructions to the obstetrical hospital, there were a few sort of quirks that happened. Somehow the father was made to wear a mask throughout the admission when he was in the isolation room with the patient and whenever he walked through the hall, because no matter what we said, the assumption was that he also must be contagious also. The staff wore N95 respirators throughout the admission, although one could argue that standard infection control might have let her out of quarantine. She had been smear negative for almost a month at the time that she went into the hospital, but we had really made this aggressive infection control plan because of the risk to the babies in the hospital, not so much the risk to the healthcare workers. And a interesting side note was that the hospital originally charged the patient for all the isolation facilities after her health insurance denied the charges due to, quote, a lack of medical necessity. Now, we have actually, through written challenges to this, had those charges reversed because we felt that they truly were necessary charges or necessary medical interventions. But I think that it just reminds us that constant education is necessary when it comes to TB in these at-risk, vulnerable populations.
Thank you very much, Jane. That was terrific. Thank you, Shailing. Now we'll open the time for discussion.
Dr. Reichman, this is Rajitha. While we're waiting for the phone questions to come in, there is a question that came in via the Q&A panel, and this could be for either one of the speakers. The question is, if a woman is on rifampin postpartum for latent TB infection, what is known about the potential effects on contraceptive methods, specifically implants such as Implanon, and is there significant risk for liver induction to decrease the effectiveness of the contraceptive?
Great. Jane, you want to handle that? Okay.
My understanding is that whenever a woman is on rifampin, that at least clinically we tell them that they should not count on a hormonal form of contraception because of the induction of the P450 system and breakdown.
Shailing, you agree with that?
I completely agree. Anytime a patient is on any antibiotic that could affect with neurometabolism, we recommend double contraception, either the use of hormonal with a second backup method, or probably better yet would be a non-hormonal method, of which we have so many at this time. An IUD was believed to be many people think that IUD should only be used in women who plan on having contraception for 10 years or more, but honestly, as long as the patient uses the IUD for 6 or months or a year, then you already have your you've already had your value, and so it would be appropriate to put an IUD, even if it's temporary. It could be removed, and the patient can have her reproductive fertility restored pretty much immediately.
Great. Okay. Any more questions out there?
So we have another question by the Q&A panel, and this is regarding recommendations for what are the recommendations regarding chest X-rays for individuals who are asymptomatic but do have a positive tuberculin skin test. And the question is based on the experience of this individual having medical providers wait until past 15 weeks after delivery before doing the chest X-ray. So again, the question is about what is your opinion on doing chest X-rays in patients who are asymptomatic? So I think perhaps a reiteration of what was already covered. Dr. Chang, if you want to cover that.
Yes, absolutely. We routinely perform chest X-rays on women with a positive PPD, regardless of how many years they have had a positive PPD, even patients who claim that they have been treated in childhood. And the reason is because during pregnancy, theoretically, their immune systems may be compromised. We don't know what has been going on in the last couple of years. There's always the risk of activation of disease. So we find that the safety profile, allows us to perform it right away. There are many people who are afraid of doing this, and they recommend that it be done afterwards. But I think safely you can recommend for patients to have a chest X-ray performed during the index pregnancy.
That actually, just in the clinical realm, in the TB clinic here in Rhode Island, we actually, most of our pregnant patients who have a positive tuberculin skin test come to us sometime after the first trimester, and we X-ray them to give them their clearance for delivery.
I think we should stress that we are all assuming, and I think Charlene alluded to this a little bit, that it has to be a shielded, collimated X-ray and an up-to-date machine.
Correct.
Yes.
Okay, any more questions?
Health Department in Maryland.
Hi.
Hi. The question we have is if that mother had still been smear positive, would the baby have been isolated from the mother if she was in isolation in the hospital? Because that's what we would do in our county. If the baby had never been exposed until delivery, would the baby have been the mother been separated?
Well, what we would have, I guess I'll take what I would have done in practice, and then I would like to hear Dr. Chang's remarks. In the TB clinic in Rhode Island, we would separate the baby that day, evaluate the baby, put the baby on window prophylaxis, and then allow the mom and baby to be together, as long as the baby was on window prophylaxis and the mom was being treated. We would then make the decisions about when to end window prophylaxis based upon when the mother's culture conversion occurred.
I can't speak about the neonatal treatment, but I do know that that we would ask that we would separate the baby to evaluate the baby, but then afterwards the mother can be reunited, provided that she practices the universal precautions and wears a respiratory mask around the baby. We certainly don't want to take away the opportunity for the mother to bond with the child, and so as long as the baby is on prophylaxis, the mother is actively being treated, and that she washes her hands and wears the mask, then she should be allowed to remain with her child.
Okay, thank you both. Next question.
Hi, I have a question. I had a patient positive TB on 4-drug therapy that became pregnant. she had finished the PZA treatment, so she was only on 3-drug therapy when she became pregnant and ended up delivering her baby at 28 weeks. And she was culture negative at delivery and had been for maybe 4 weeks or 6 weeks. And I'm just curious, would there be any reason that you would test, and this is pulmonary TB, would you test the placenta for granulomas on that baby just as a precaution?
Charlene?
It is recommended to evaluate the placenta every time the patient has a preterm birth. So outside of the context of tuberculosis, if a patient has a premature birth, it should always be evaluated for evidence of chorioamnionitis to look for abnormal transformation of the arteries, to give us an indication why the patient delivered early. And while they're there, the physician should be asked to look for evidence of granulomas. Again, as I mentioned in my slides, it doesn't mean that the fetus will be affected or that the neonate at this point, but it certainly can give you an indication as to whether or not the mom had any, active disease that was not picked up by sputum if she had if she had extrapulmonary tuberculosis. But I wouldn't. I think it should always just be ordered, and it doesn't hurt. But it wouldn't necessarily change your management of the fetus.
Just out of curiosity, Charlene, is there a cost to examining the placenta added to the cost of delivery and all these other things, like the insurance company that billed Jane's patient for, would they add some big amount for just examining the placenta?
There is a cost associated with sending the placenta. I believe it's just like any other bill that you would send. The pathologist may bill for several $100s and in the end make a few dollars. I think in this case, certainly the infectious control department could be contacted, and they can ask them to waive this charge. I mean, we routinely examine placenta for research reasons. They're kept around. It really shouldn't deter medical health providers from sending the placenta for an evaluation.
Fine. Okay, more questions, please?
Lee, this is Jane.
Hi, Jane.
Just one other interesting comment was that we actually, because this patient had been sitting in the obstetrical office, we actually, as part of our contact tracing, actually had to go back and test many of the pregnant women that were sitting in the obstetrician's office at the time of at the time of the patient's visits. And I don't have it off the top of my head, but we actually had a number of conversions and treated I just wanted to raise the issue that all of those pregnant women who we found with positive skin tests as part of contact tracing, we treated their latent TB infection during pregnancy, as Dr. Chang mentioned, as one of the categories where you would do that.
Of course, this was a laryngeal case, which is thought to be highly infectious. I would suspect with a pulmonary case, or you probably have less conversions.
I would think so.
Very interesting. Dr. Bolanowski, we have a thoracic surgeon here. Paul?
I want to just relate a personal experience I had about 40 years ago when I was an intern at Yale, and my senior resident and I, were doing a bronchoscopy. And Dr. Linscock, who was our attending, looked down the scope. We saw this beefy red larynx. He said to us, "Gentlemen, that's the most infectious form of tuberculosis. I'm leaving." 6 months later, my senior resident came down with active tuberculosis. I was negative. I was the lucky one, though I had had TB as a child. So I can't stress the importance. If you see a beefy red larynx, think of tuberculosis first and foremost, and follow isolation techniques to the T. Thank you.
Okay, thank you, Paul. Any other comments before we close?
Dr. Reichman, there's another question about initiating treatment for latent TB infection in the postpartum period. The question is that in this person's policy in their health department that they wait for 6 months due to a presumed increase in liver toxicity. And so they wanted to know whether they should continue that practice. Is there any risk of increased liver toxicity in initiating latent TB infection treatment postpartum?
Charlene, do you want to handle that one?
I haven't heard of that policy. I think there are no strict criteria, but I would recommend that any patient in the immediate postpartum period be referred to an appropriate center for treatment. And the reason is because of the incredible loss of compliance. After delivery, the patient sees their obstetrician perhaps once, and that's usually at their 6-week visit, and a lot of our patients miss that visit. So delaying things for 6 months potentially could just mean a loss of follow-up. The risk of hepatitis secondary to treatment is so low that I think that policy should definitely be revisited.
Jane?
Oh, thank you, Lee. Do you know, there's not any literature that I know of that says in the postpartum period there's an increased risk of hepatotoxicity. Our usual regimen in the TB clinic in Rhode Island is that most women we bring back about 3 months postpartum. But I have to say, in our data, we've actually gotten we have pretty good retention. And I think that the reason that we have pretty good retention postpartum is that we use that evaluation when we see the patient referred to us for evaluation of their LTBI in pregnancy. We specifically make an education effort over a couple of issues. One is that we remind patients that they can breastfeed while they're on their treatment for latent TB infection, because in the past we found that many of the women opted out of coming to an appointment because they thought we were going to tell them not to breastfeed. So we try to tell that to them at that appointment during pregnancy to stave off that misconception. Also, in our patient population, at least in Rhode Island, you know, a lot of our patients are really, with TB, are marginally insured. You know, TB remains an issue of poverty. So that one of the issues that we've actually found is that moms lose their health insurance once they deliver the baby, although the baby is covered in Rhode Island. So we also specifically tell our pregnant women that even if they lose their health insurance, that their care at the TB clinic is free. And so we try to actually do a lot of this early education to avoid that loss of follow-up at the postpartum visit.
I'd like to comment that this is very true in patients who have Medicaid or who have PCAP Medicaid.
Yep.
This insurance policy basically expires as soon as the patient is 6 weeks postpartum, which is why not only is it important for us to reiterate the fact that, you know, every time she is pregnant, pregnancy care is provided, but treatment for latent TB is provided. And there are also many programs providing birth control and contraception to women that are free and sponsored by either private organizations or through the government that the patient can have access to. This is just something that a lot of women do not realize and don't take advantage of.
Okay, well, thank you very much, both. Thank you very much to all the questioners. And thank you, speakers, for an afternoon of myth-busting. I think some of the questions showed us that there's still a lot of misconceptions out there, and the losers are our patients and their babies. I'd like to thank our faculty for sharing their knowledge and experiences with all of us. The New Jersey Medical School Global Tuberculosis Institute provides medical consultation to providers in the northeastern region, even to obstetricians. So please feel free to call us at 1-800-4TB-DOCS. And this concludes the conference. Many thanks for your participation.